Hey everyone, so here's the video on reproductive disorders, and I'm going to first go over disorders of the breast, then followed a little bit by specific disorders experienced by females, and then briefly over with males. So let's get started. Actually, I have a PowerPoint. I can kind of go along with it, and you can follow along. I'm not going to read every little bit, but just to really get you guys to understand a little bit better, work with it, the kind of questions you'll see on the NCLEX, kind of questions you'll see on exams, and we'll go from there. So you can see here first, obviously to learn about breast cancer and breast care, you have to know how to do a breast assessment. Big thing is oftentimes the patients doing their own breast exam and also the healthcare providers doing a clinical breast exam. So sometimes people confuse that. There's self-breast exam, which is the patient doing it themselves. And then there's a clinical breast exam where the nurse or the physician is doing it. So in this case, really, you're focusing a lot on, looking at the breast, which we'll get into some specifics about that, palpation, and then the lymph nodes. And you can see here on this, this picture on the top right, it says the tail of Spence. That's where a lot of, you can say, malignant cancers, tumors will end up in that tail more than not. Also, men do get breast cancer. That's sometimes not everybody thinks about it. I actually have seen a patient, a male, who had to have one breast removed and then his next one due to breast cancer. So it does happen. Doing clinical breast exams, you can see the different positions the patient has to go in, arms up, arm down, just to really see the symmetry. Then palpation, you can see there's different approaches. You can do radial approach or vertical. Really just make sure that you're really covering the entire breast and assessing it. Just here's more examples, just using different techniques and all that to see. And what you really want to feel for is, there's going to be, in people's breasts, there's all kind of differences. Sometimes there's things that are, changing what men sees. Those are kind of normal, especially if it's something that feels soft and it's movable. Those are generally things you don't worry about. The things that are really worrisome sometimes feel like hard. They're irregular shape. They might feel like a pea. They might almost feel like they're attached to the bone. Those are things that we really are concerned about for our patients. And you can see here, very important to examine under the arm where, the axillary node is, and again, near that tail where cancers can happen. But breast exams themselves is generally not only what we do. You can see after 45, we do mammography, and generally that's every year. Some people start earlier if the physician feels or the healthcare provider feels that there's a bigger risk for a patient, but generally it's at 45. If they do find something suspicious, they can do a needle biopsy. And that basically just helps us, look at the tumor in the cells and see what kind of thing is going on. If it's a tumor, is it cancerous, is it malignant, how aggressive it is, we can tell by looking at it under the microscope. You can also do surgical biopsy where they actually remove it. That's actually called a lumpectomy. They're not removing the whole breast, they're just removing the lump out of the breast that they're concerned about and then examining it. But there's many people worry that they have breast cancer, but oftentimes a lot of them are benign conditions. Some people just generally might have breast pain for certain periods, which is called mastalgia. It could be due to cysts, things like that. It could be due to a fibroid, or we call it a fibroadenoma. But those are very common. You can see some other things listed here, but those are the really common ones that will happen. Malignant conditions, however, you can see all women have around a 12% chance, which is 1 in 8. There's over 200,000 new cases of invasive breast cancer a year, which increases with a woman's age. So the older a woman, the more chance they have of breast cancer. And research is really showing that there's a lot of socioeconomic differences. It can be based on race. So there's different, conditions that are affecting women in different parts of the world, depending on, socioeconomics and education. There's a lot of factors to it. You can see here there's ductal carcinoma in situ, which really just means that it's of the milk ducts. You can see in these pictures, and we're going to go over this in a second, how you can see in this picture there's nipple inversion. You can kind of see like the breast has that almost looks like an orange peel, which is something that comes up. These are things that you're looking for when you're doing these breast exams. But again, there's no real specific, oh, this will definitely cause breast cancer. But we know that, there are genetic factors, there are hormonal factors to it. The biggest things, there's no evidence that show that breast implants can do it, or that wearing certain deodorants or even bras could do this. There are some links, but nothing 100% about long-term smoking. And then people, you could see night shift worker really, people that don't get regular sleep, because again, that really affects the immune system. This piece here, BRCA1, BRCA2, this is a risk factor that some people have. And we spoke about this before when we went over cancer. And this just means that as cells start mutating toward getting cancerous, if a person has BRCA1, they kind of already have the first mutation. So they're somewhat on their way to developing breast cancer. Some people, they've actually, right, we talked about this, there's different types of surgeries. Some people have this. It's not necessary. It's always up to the healthcare provider working with the patient. But some people have actually had their breasts prophylactically removed that have this factor. Other guidelines we have, again, women at high risk, benefit for MRIs. Clinical breast exams should be done twice a year starting at 25. Sometimes they actually do chemo prevention using tamoxifen. You can see prophylactic mastectomy is there. And you see that you don't really see that much emphasis anymore on self-breast exam every month, because what was happening was a lot of women were reporting, oh, I have a lump, or I have this, I have that. And a lot of physicians, they kind of, go with the anxiety of the patient. And there was almost an overabundance of people having mastectomies and surgeries that didn't always need it, but they were just doing this in case. So a lot of times you can see we're focusing more on the MRIs, we're focusing on the, mammography, and then the clinical breast exam. Here we go. So when, again, doing these clinical breast exams, things that you're looking for, dimpling of the breast, if there is retraction or increased venous prominence, nipple inversion of one of the nipples that wasn't inverted before. And then there's this part where it says, I'm not great at French, but it says peau d'orange, right? Like it looks like an orange almost. If you look at the way that the pores start to open up, and that kind of almost pattern of an orange that you can see, that's also a sign of possible cancer in the breast. Here you can see somebody, there's just different kind of like retraction of the skin. You can see that orange kind of thing going on there, all those different things in these pictures. Here's a question. It says the skin is thick and hard. She thinks it looks like an orange. How would you document that? And that's C, right? Peau d'orange, which means that the skin looks like an orange around the breast. When we start looking at the breast, we want to, do tumor node metastasis, which tells us, how big is the tumor? Is it spreading? Is it not? And the big thing, if the bigger the tumor, the more it's spread, obviously the mortality rate and the treatment's going to be more difficult. Surgical management, well, we have our mastectomies. And, be careful of when you think about mastectomy, a lot of people will confuse the lumpectomy, the mastectomy, radical mastectomy. So you can see a mastectomy itself means removal of the breast, but generally that's not enough. So they'll do a radical mastectomy, but a fully radical mastectomy removes a lot of muscle, lymph nodes, and the breast, where a modified doesn't remove as much. It's a little bit more conservative, so the patient doesn't have such a severe recovery, but this all depends on the surgeon, on the x-rays, on the mammographies, on the MRIs to see how far the tissue is really gone. Your job as a nurse is not really deciding the surgery, but how to respond to the surgery, right? So more the post-op care. So as they go undergo the surgery, obviously, again, that's an OR nurse. That's really not on the NCLEX, not really on our exams. You know, as we're getting the patient ready, do they have emotional support, right? Like losing anything, losing a limb, losing a breast. There are a lot of emotional pieces to that. So do they have a support group? Do they have enough education about all that? A lot of people have anxiety, not only because they're losing their breast, but also about cancer itself. So there's a lot of, you know, counseling that these patients will need. Pain management education, self-care, because as we'll get into, right, there's a lot of things that somebody who's going to have breast cancer needs to know. Like, for example, in the arm where the breast removes, especially with a, you could say a radical mastectomy, they're very high risk of lymphadenopathy. So you don't want like taking blood from that arm. You don't want to be taking blood pressures from that arm. You don't want to be putting IVs in that arm. Anything that could really, you know, cause infection or inflame that arm, we want to teach the patient to avoid. You're also going to tell the patient they'll be coming home maybe with a surgical drain, maybe like, you know, one of those JP drains. So they have to know how to empty and do that. If that's something you haven't done, you know, or seen, there's a lot of videos on how to empty JP drains and all those things. Here you can see a woman, here's her incision. You can see those JP drains are there. Some of the nursing diagnoses you can see: disturbed body image, risk for sexual dysfunction, and of course pain, right, and discomfort. For post-op, what are our priorities here? Of course, you can see pain, although is pain always a priority? It can be in some cases not. Of course, in this case, if somebody had surgery, my big priority would be more the neurological status of the arm right away, right? So you want to do the neurovascular check of the arm and, you know, make sure that the patient's getting circulation, that the nerves are intact. And then I'm going to start thinking about pain, right? These are always things you want to think about because, you know, I always say this, pain, of course, is awful, but you don't lose function. You don't die of pain. Pain is usually a signal that something is wrong. Of course, after surgery, you're going to have pain, and generally the medications can relieve it. But if there's unrelieved pain, or if there's other things like neurological issues, circulatory issues, that's a bigger concern. And the biggest thing we're worried about is this lymphedema, where the arm can just get really swollen and enlarged. You can see surgical site management. They can start, you know, when they're showering, and all these things are here. No heavy lifting for around 4 to 6 weeks, nothing more than 5 or 10 pounds. Here's that Jackson Pratt device we spoke about. After surgery, as they start recovering, we're going to start teaching them how to do arm exercises. That's very important. This, you know, of course, this isn't like the first few days. This is, you know, days after they start recovering slowly. But the big thing you're teaching them, no blood pressures, no injections, no blood draws of that extremity. Even, you know, avoid insect bites to that arm. If they're going to garden, if they're going to cook, they don't want to, like, you know, get injured. Even shaving, you know, under the arm, they should maybe use an electric razor. You can see here, you can see one arm is swollen, one is not. That's also a sign. And then lymphedema really is just characterized by that chronic swelling of usually one limb. A lot of physical therapists actually treat lymphedema because they'll actually do wrappings and certain exercises for the patient. Also, you can see sometimes if the patient has a hematoma after surgery, this obviously a sign that there's bleeding going on. You should let the surgeon know right away because obviously there's a lot of blood that could be, you know, accumulating there. Here's you know, also a picture of infection of the breast. That's also something obviously you want to be concerned about. And you can see they kind of drew that line around it to see how much the cellulitis is spreading of the infection. So, you know, but again, infection doesn't happen for a few days, so that's not your initial priority. This is usually something that comes days later after the surgery. And I'm going to actually stop at this point, and then I'm going to restart with the second part of the reproductive.